So the CDC just recently sent out their revised recommendations on the use of opiates for chronic pain management. So right now we're dealing with a very significant opiate addiction epidemic. About 15 to 20 years ago, the thought was that opiates are good for pain management, and more opiates might be better for better pain management. And so a lot of our prescribing habits and our regulatory habits got very loose, lazy. In general, in medicine, thought that almost anybody could use opiates safely, and that's simply not the case, as we see a significant number of patients addicted or co-addicted to a variety of pain medicines. One of the other concerns is with the overprescription of opiates in the United States, not only a patient who is prescribed these medications has access to them, but when that patient goes home and puts their medication into the medicine cabinet, other people have access to that medication as well. And this is another very big safety issue. There are dozens of people that die in the United States every day from accidental opiate overdoses. So the CDC guidelines are an answer to that. The CDC is basically recommending that all stones be unturned with regard to other alternative modalities of pain control before you get to the opiate. In addition, the CDC has set some limits or some guidelines for how high of a dose a patient should be on before you start enacting other safety mitigation efforts. It has also discussed the use of opiate reversal agents such as naloxone, which can immediately reverse the effects of opiates were a patient to accidentally overdose. And in fact, in many states, just recently in Illinois, naloxone is now available in most pharmacies, in many cases without a prescription. I think the new guidelines restart the conversation. We have all been complaining about the opiate addiction problem in the United States. It is an epidemic, but we have been slow to respond to it in any meaningful way besides the end user and legislation surrounding criminal activity, lying, cheating, stealing to get more opiate medications. But I think the guidelines restart a conversation. It sort of resets the thermostat, if you will. Don't start with opiates. Let's try other things first. There are cases, plenty of cases, where opiates are the best thing for a particular patient. But we need to get to that point where we've identified the risk factors for addiction, the predictors that opiates are going to be helpful for a particular patient, and that we have a long-term strategy in mind. I think there's a reasonable concern for that. I think patients who have chronic pain and practitioners who treat those patients are concerned that there could be a regulatory overreach, making it more and more difficult for patients to get the medications that they need. This, however, is not the only governmental agency that has put forth an effort to restrict access to make things more safe. A couple of years ago, hydrocodone, which used to be a drug that you could call into a prescription, that is now accessible only through a handwritten or printed prescription that a patient must get. Yes, I think there are concerns, but again, the CDC guidelines are an answer to a major problem that we have. And I think all of these changes that are occurring in medicine really occur on a pendulum. So we swing back and forth on that pendulum, trying to find the perfect sweet spot where everybody is happy and everybody is safe. Well, there are a few tools that can be used and a few processes that can be followed. First, most emergency rooms now, or emergency room physicians, don't recommend more than 2 or 3 days worth of medication being prescribed to the patient. That would give them enough time to treat their pain and get back to their primary care doctor during regular business hours in a non-emergency scenario. Whereas years ago, there were patients that could go to the emergency room with low back pain and get a week, a month, 2 months worth of medication, which probably wasn't needed. Most states now have a online checkup system where you can assess whether a particular patient has been getting medications from multiple providers. Now, that's a voluntary reporting system, but any physician can have access to that registry. So if you had a patient come into the emergency room with low back pain and they were new to the emergency room staff, one may want to take a look at that registry and see if that patient has been doctor shopping, going from emergency room to emergency room, trying to find more and more medication. That's one way to do it.